Welcome to another deep dive. If you're tackling the MSRA, well, this one's definitely for you.
Absolutely. We're diving into Granuloma annulare today.
Yeah, a skin condition that, pops up in revision quite a bit. We're pulling the essential high-yield nuggets straight from the source material.
Mm-hmm. Cutting straight to what you need.
Our mission today is simple. Give you a crisp, clear overview. We'll cover what it is, maybe why it happens, what it looks like.
And crucially, how it's managed. All geared towards that exam prep.
Think of this as your shortcut to understanding granuloma annulare for the MSRA, laid out clearly, conversationally.
Feels good.
So let's unpack this. At its core, the sources describe granuloma annulare as benign, so harmless.
Right, that's key. Benign.
And it's characterized by these raised circular bumps on the skin.
That's the basic picture, but diving into the definition a bit more, they're not just any bumps.
Okay.
The classic presentation involved these raised, sort of reddish or sometimes skin-colored bumps, and they often form these ring-like patterns.
What's the annulare part of the name?
Exactly. And location-wise, you're most commonly finding them on hands, feet, elbows, and knees.
Okay, key spots to remember. Hands, feet, elbows, knees.
Definitely. And looking even closer at the individual lesions, the sources get specific. They call them papular.
Which just means small, raised bumps, right?
Yep. And they can be slightly hyperpigmented, so a bit darker than the surrounding skin.
Okay.
And often they have a centrally depressed area, almost like a tiny crater in the middle of the ring.
Interesting detail.
And what's really interesting, tucked right there in the definition section of the sources, is this mention of a weak link to diabetes mellitus.
Huh. Okay. So that association comes up early.
It does. It's flagged right from the start, even though it's described as weak, something to keep in the back of your mind.
And beyond that classic look, the sources emphasize it's not just one single entity.
No, definitely not. There are different types, and knowing these is really crucial.
Why is that?
Because they differ in how they look, who tends to get them, and importantly, how they're managed. The sources list localized, generalized, subcutaneous, and perforating types.
Okay. Localized, generalized, subcutaneous, perforating. We'll need to remember those.
Yeah, we'll definitely circle back to the specifics of each later on.
All right. So we have a picture of what it looks like. Now, the big question, why does it happen? What do the sources say about the etiology, the cause?
Well, this is where it gets a bit fascinating, maybe frustrating too.
How so?
The cause is explicitly stated as unknown.
Oh, right. One of those.
Yeah. But the prevailing theory, according to the sources, involves inflammation, driven by the immune system somehow.
Okay, so an immune thing, but we don't know the trigger.
Pretty much. The sources list several possible associations, things that might potentially set off this immune response.
Like what?
Things like infections, certain medications, conditions like diabetes, there it is again, and thyroid disease, maybe other autoimmune disorders too.
So a range of possibilities, but nothing definite.
Exactly, just potential links. And there's even a specific note suggesting the inflammation might be linked to TNF-alpha.
Tumor necrosis factor alpha.
Yeah, a key inflammatory molecule. But again, it's a suggested link, not proven causation.
Okay, so if the cause is murky but maybe linked to these triggers, who's most likely to get it? What about risk factors?
Well, the sources say it can happen in people of all ages.
Right.
But it's noted as being more common in children and young adults.
Okay. Younger age group predominantly.
Seems so. And interestingly, no specific gender or racial preference is mentioned in the material provided.
Good to know. And those potential triggers again, diabetes, HIV.
Yeah, they reiterate that possible link with conditions like diabetes mellitus and HIV.
Yeah.
But, and this is important, they also stress the link is unclear.
Unclear. Okay, that ambiguity is a theme.
It really is. The connections might be there sometimes, but they're not universal, not fully understood.
Right. Let's go a layer deeper than pathophysiology. What's actually happening under the skin at that cellular level?
So, the thinking is it's an immune response, triggered by some kind of unidentified antigen.
An antigen being anything the immune system sees as foreign?
Exactly. But we just don't know what that something is in granuloma annulare.
So the immune system reacts. How?
The key thing you see under the microscope is this accumulation of immune cells. Specifically, the sources highlight macrophages.
Macrophages, okay. The big eaters of the immune system.
Kind of, yeah. They gather together in this characteristic pattern, forming clumps or nodules, and those are the granulomas.
Ah, hence the name, granuloma.
Annulare. Ring-like collections of these granulomas But just like the initial trigger, the exact mechanism, why the immune system forms these specific clusters in this condition.
Still not fully understood.
Still a bit of a puzzle, yeah.
Okay, now this next bit is super important for exams. Differential diagnoses.
Absolutely critical.
Granuloma annulare can look like other things. How do we tell them apart? What does the source material list?
This is where knowing the details really pays off. The sources list 9 conditions that can look similar. 9.
Wow, okay. Let's hear them.
Lichen planus, sarcoidosis, rheumatoid nodules, tinea corporis, that's ringworm,
Right.
pityriasis rosea, nummular eczema, psoriasis, erythema chronicum migrans, the Lyme disease rash,
Okay.
and even leprosy. It's quite a list.
Definitely. So with all those possibilities, what's the key thing the sources give us to differentiate granuloma annulare?
It often comes down to the surface texture.
Texture.
Yeah. Granuloma annulare is often distinguished by the absence of surface changes you see in many of those others. Like scales. Think psoriasis or eczema, often scaly. Granuloma annulare usually isn't. Or vesicles, small blisters. Or pustules, pus-filled bumps.
So it's smoother.
Exactly. The sources note its smooth appearance, that smooth, raised, ring-like look, without significant surface scale or change, is a big clue.
Got it. Smooth operator. Okay, let's zoom out. Epidemiology. How common is it, especially thinking about the UK, for the MSRA?
Well, interestingly, the actual prevalence in the UK is unknown, according to the sources.
Really? Okay.
Yeah, but it's generally considered rare. Just to give a figure, the source provides a U.S. incidence number, which is about 0.04%, so not common.
Okay, where? And what about those different types we mentioned earlier? Does the epidemiology differ for them?
It does, and this is definitely high yield for exams.
Right.
The localized type, by far the most common, makes up the majority of cases, especially in people under 30.
Localized, most common, younger people.
Okay, then generalized. Less common, maybe 10–15% of cases, and you see it more often in adults.
Generalized, less common, adults.
Subcutaneous, those lumps under the skin, typically seen in children.
Subcutaneous, children. And finally, perforating. That's the least common type. Often causes symptoms and seen in children and young adults.
Perforating, least common. Children, young adults. Symptomatic. Got it. Knowing age groups for types seems key.
Okay, let's bring this back to the clinic or the exam room. Clinical features. Paint us a picture of what you'd actually see for these different types.
So generally, as we've touched on, you're looking for smooth, firm, raised bumps or plaques.
Right.
Forming those characteristic circular or ring-like patterns. Color can vary skin-colored, reddish, sometimes violaceous.
Violaceous meaning purplish.
Yeah, purple or violet-colored, and typically they're asymptomatic. No itch, no pain usually.
Usually, but sometimes.
Sometimes, yeah. The sources note occasional itching or tenderness. And these things can stick around months, even years.
Persistent. Okay. Now, the specifics for each type.
Let's break it down. Localized, usually asymptomatic. Forms those classic arcs or rings, maybe 1 to 5 centimeters across.
Replication.
Hands, feet, fingers, arms, legs, those common spots. The individual bumps, the papules are small, 1–2 millimeter, maybe some redness. And that center often looks a bit depressed and might be hyperpigmented, darker.
Okay, classic picture for localized. What about generalized?
Similar look, but way more widespread. Many more lesions, often scattered diffusely.
Right.
Sometimes they join up, coalesce, forming larger annular plaques, maybe 3 to 6 centimeters.
Yeah.
Commonly on the limbs or the trunk.
More widespread, larger limbs trunk.
Okay.
Subcutaneous.
Remember, these are under the skin. They feel firm, usually not tender. Common spot is the front of the shin, the vertebral surface.
Oh, the shin, okay.
Can be just one lump or a cluster. Usually mobile under the skin, unless maybe on the scalp.
Got it. And the last one, perforating.
Starts as small papules, 1 to 4 millimeter, maybe some redness. Can be solitary or many, can coalesce into rings.
Okay.
Key point from the sources. In middle-aged or elderly folks, these perforating lesions can be larger and more ulcerated.
Ulcerated like open sores.
Yeah, and they can leave scars when they heal hyperpigmented or hypopigmented marks.
And location for perforating.
Predominantly on the extensor surfaces, back of the forearms, front of the shins, or the back of the hand, the dorsal surface.
Okay, lots of detail there. Let's try a quick exam style scenario.
Good idea.
Imagine a question describes, say, a 25-year-old. Smooth, non-itchy, reddish rings on the backs of their hands. Rings are about 2 centimeters across, slightly depressed, darker centers, based strictly on those features.
Sounds like textbook localized type, doesn't it?
Exactly. Smooth, non-itchy, reddish rings, the size, location on hands, the depressed, hyperpigmented center.
It's all those points we just covered for localized. That's how you use these details.
Perfect. Okay, so you suspect granuloma annulare based on the look. How do you confirm it? What about investigations?
Right. Another high-yield point here. Diagnosis is primarily clinical.
Just by looking.
Mostly, yes.
Yeah.
Based on that characteristic appearance, the patient's history, the presentation we just discussed.
But investigations can be used.
They can, in some situations. The sources say a skin biopsy may be considered.
Why would you do a biopsy?
Two main reasons. To confirm the diagnosis if it's not perfectly typical, and importantly, to help rule out those other conditions on that long differential list.
Right, like sarcoidosis or lichen planus.
Exactly. If there's doubt, biopsy gives a clearer answer.
And what about blood tests? Lab work?
Usually unnecessary, according to the sources, unless you suspect an underlying condition.
Yeah.
Back to those possible associations. Diabetes, thyroid problems. If the picture suggests something systemic might be going on, then labs might be needed, but not just for the granuloma annulare itself.
Okay, clinical diagnosis mostly, biopsy if unsure, or to rule out others, labs only if suspecting underlying conditions. Makes sense.
Yep.
So, you've made the diagnosis. Now what? Does it always need treatment? How is it managed?
This is absolutely key for management questions. First point. In most cases, treatment might not be needed at all.
Really? Why not?
Because it often resolves on its own over time, especially the localized type. So often reassurance and just watching it is the best approach.
Watchful waiting.
Exactly. Treatment is usually only considered if the lesions are causing symptoms like itching or tenderness, or if they're a cosmetic concern for the patient.
Okay. And if you do treat, what are the options? Does it vary by type?
It varies quite a bit. Let's take the local type first, since it's usually asymptomatic and self-limiting.
Often no treatment needed.
Right. But if you do intervene, first-line therapies mentioned are topical corticosteroids creams applied to the skin or intralesional corticosteroids.
Injecting steroids right into the lesion.
Exactly. Other options listed include cryotherapy, freezing them, and laser ablation.
Okay, local treatments for local disease. What about generalized?
That's different. It's more widespread, more likely to cause cosmetic issues, so it often needs more intervention.
Right.
The sources list a whole range of options here. PUVA treatment, that's phototherapy.
Light therapy.
Yeah, so Sorolin plus UVA light. Also oral meds, oral steroids, dapsone, cyclosporin, methotrexate, antibiotic combinations, antimalarials, even isotretinoin.
Wow, quite the list. Anything else?
For really stubborn recalcitrant cases, the sources mentioned TNF inhibitors, things like infliximab and adalimumab, powerful immune drugs.
Okay, systemic treatments for generalized disease. What about subcutaneous lesions?
Especially in kids, reassurance is often the main thing. If needed, surgical excision cutting them out can be considered.
Simple excision if necessary. And perforating lesions.
The sources have a telling comment here. They say treatment options are often disappointing.
Oh, dear. So hard to treat effectively.
Seems that way, yeah.
Challenging.
Okay, let's try another mini vignette for management. Say a 40-year-old patient, widespread, slightly itchy, reddish-purple annular plaques on arms and trunk. Diagnosis. Generalized granuloma annulare. According to the sources, which wouldn't be a typical first-line option, A, topical steroid cream, B, oral methotrexate, C, PUVA, D, intralesional steroids.
Okay. Well, we said topical and intralesional steroids are first line for localized disease.
Right.
For generalized, the list included systemic options like oral methotrexate and PUVA.
So
topical or intralesional steroids wouldn't usually be the first go-to for widespread generalized disease. You'd likely need something systemic.
perfect. Shows why knowing the management by type is so important. Okay, what about the long-term picture? Prognosis. Generally speaking, the sources say it's typically self-limiting. It often goes away eventually.
That's good news. But does it vary by type again?
It does. Localized cases usually resolve within about 2 years. Hence, the reassurance approach often works.
Okay.
But generalized cases, they can last much longer, maybe up to 10 years, and they're often resistant to treatment.
Oh, wow. 10 years.
Yeah, and they have a high risk of coming back even after they clear. More frustrating.
Definitely. And subcutaneous.
Those might resolve, but they can also recur elsewhere on the body.
Right. So mostly good prognosis for localized, more persistent and recurrent for generalized.
That's the gist of it.
Are there any serious problems associated with it? Complications?
Thankfully, the sources state it's usually benign and rarely leads to serious complications.
Ew.
The potential issues are mostly related to the lesions themselves, cosmetic concerns, or itching and tenderness if they happen to be symptomatic.
Makes sense.
And the sources also mention that having recurrent or persistent lesions can be emotionally distressing for people, which is understandable, right? A visible, long-lasting skin thing can be tough.
Absolutely. Anything else complication-wise?
There's one other important point, and it loops back to those possible associations we keep mentioning.
Diabetes, thyroid.
Exactly. The sources stress that close monitoring is needed to detect any potential underlying systemic diseases or associated conditions.
Ah, so even though the granuloma annulare itself is benign, its presence might be a clue to look for other things.
Precisely. While the link isn't always clear-cut, the possibility means you need to stay vigilant and monitor for signs of conditions like diabetes, thyroid disease, or other autoimmune issues potentially developing.
That adds a layer of clinical importance, doesn't it, beyond just the skin?
It really does.
Okay, well, that brings us towards the end of this deep dive into granuloma annulare. We've covered the definition, potential causes, risk factors, pathophysiology,
Differential diagnoses, epidemiology, all those clinical features for the different types.
investigations, management strategies based on type, prognosis, and potential complications. All pulled straight from the source material for MSRA revision.
Hopefully a really focused overview.
Yeah. Thinking about it all, what's a final thought to leave our listeners with?
It's quite striking, isn't it? How this relatively common, usually harmless skin condition still has this unknown cause, this mysterious immune response driving it.
Right.
And yet, at the same time, it warrants this vigilance for potentially serious underlying systemic diseases.
It's a good reminder that even seemingly simple presentations can have hidden depths or associations.
Exactly. A great principle for the MSRA and definitely for clinical practice, too. Never assume. Always consider the bigger picture.
Well said. Okay, before we wrap up, if you're looking for more free MSRA revision resources, do visit freemsra.com.
And for the full premium revision toolkit, you can head over to passthemsra.com.
Thank you so much for joining us for this deep dive.
Yeah, hope it was helpful. Keep up the great work with that revision.